So this is a case of a 75-year-old man who was working in Chittadi Public Library, and he was collapsed in the Cotton Kumli Road, KK Road, but he was walking, returning to the home. So he is known to suffer with angina. This is his ECG recorded on arrival. First of all, we start with the heart rate of the ECG. The heart rate, so seems not at all regular in rhythm. In the 50 big squares. From here all the way to here is a 50 big squares. In 50 big squares, there is 1, 2, 3, 4, 5, 6, 7, 8. QRS complexes or beats in 50 big squares into 6. So here comes 8 into 6, that is 48 beats per minute. It's a bradycardia. So it's clearly a bradycardia. Next, we'll think about the rhythm of the ECG. As we all know, you see that the intervals are different, but you see that all the P waves are following QRS, but the intervals are different. The QR interval, such thing. So it's not regular. So rhythm is irregular. Next is the axis, right? Rhythm axis. For that axis, we check lead 1, lead AVF, lead 1 is positive, lead AVF is positive, you check lead 2 is also positive. So it comes just a positive deflection, so it's a normal axis. Now you check the P wave. Okay, you check the P wave. First wave is the P wave. In P wave, you check the leads clearly. In the lead 2, 2, 3, in the inferior leads, you see that the P waves are spiked P wave, spiked this P wave. It is suggestive of a P pulmonale. Discussing of pulmonale, it can be seen in many forms like COPD. It can be seen in right-sided heart stenosis, like a tricuspid stenosis, or it can be CHD, congenital. Many are there, but we cannot clearly define it as a this disease. Okay, so it's slightly peaked P wave in 2 and 3. So next, now we'll discuss P wave, then PR interval. So the normal PR interval is 120 to 200 milliseconds, that we all know. Checking the ECG here, you see here a P wave. You check this one. This is a P wave and the PR interval gap this much. Here is this much. Here is this much, and there is a drop. So it could be. We could say this is a 320 milliseconds. Here it is 360 milliseconds. Here it is 400 milliseconds. But here the P wave is not conducted to form QRS, so there's a block. Okay, so it's clearly it's a second degree heart block. Among that, it is type 1, that is progressive prolongation of PR interval followed by a drop. It's also called Winky back phenomena. Okay, next comes the Q wave morphology. Q wave. Next comes the Q waves. You observe the ECG, any pathological Q waves are seen here or not? We check the lead 2. No pathological Q wave anywhere in the lead. So you cannot find any pathological Q wave anywhere in the lead. So the Q waves are normal. Next, what we check is the QRS complex. The QRS complex, QRS complex. Checking the QRS complex, you see the QRS complex. The QRS complex is almost, you check the lead 2 or lead 2 here. This is 1, 2, 3. 3. You clearly see here that it's less than 3 small squares, QRS complex. Okay, less than 3 small squares. So you write it as QRS complex is less than 3 small squares. So it's normal. Next comes the ST segment, the very important. Since the patient is having angina and he collapsed, so you check the ST segment very clearly. Okay, we'll told when you're looking at the ST segment, we see that in 2-3 AVF, in 2-3 AVF, you see this 2-3 AVF. This not a ST elevation, but mild cooling of ST segment. So we need another serial ECG monitoring to confirmation. So we cannot currently tell it as a ST elevation. Okay. For what about T waves? About T waves, you see the anterior leads. In anterior leads, there is a, you see here, there is tenting of T waves. Okay, tenting of T waves. So we can write here as a ST segmented 2-3 AVF ST cooling. Then we can give a diagnosis T segment T wave tenting, tented in anterior leads. So finally, what we can conclude the diagnosis. So we can tell that as we know that this is a heart block, type 2 Mobitz phenomena, Winky back. So it's a Mobitz heart block. It is also called Winky back phenomena. Winky back phenomena, Mobitz. Then you could see that P pulmonale wave, P pulmonale. And you can also see that tended anterior T waves. So what we conclude here is the patient has collapsed. The patient has collapsed, probably because of the higher degree block, and since this is a tended T waves, you should check the potassium level, because in heart blocks there is a common association with the hyperkalemia. So you should check the potassium level also in this case. And you also CDD monitor the ECG, because that 2-3 AVF leads, we should be more confirmatory. Thank you.